I'm Suniti Nimkar, and I'm a surgeon, and I'm the director of the Breast Care Center at South Shore Hospital in conjunction with Dana-Farber Cancer Institute and the Brigham and Women's Hospital.
Do you find that women are concerned about being misdiagnosed, or is there more chances of having it done as they get more sophisticated about doing tests? Either it's a false positive and they go through all these tests, but maybe more that a diagnosis is actually made and then it turns out later that it's found out it was incorrect.
The idea of overdiagnosis or finding things that require procedures, that's really important. Everything we do in medicine has risks, whether it's having your blood drawn or whether it's having a CAT scan. We as practitioners constantly are considering a scale, a risk-benefit ratio of doing a particular procedure or asking a patient to go through something. Even the simplest of procedures, you really have to think every time, is this something that's going to yield information that's going to be important for this patient's care? The reason that mammography is such a good screening tool is because it really has very low risk. So the best screening tools are tools that have very low risk and can be used in a wide population and can give you some good information. There are situations where it can be that, our flags go up and maybe it's not something significant. But there's a couple of things that you can do in that circumstance, and I think that it's important to emphasize. One of the things, for example, that our imaging facility does is things are second read. And that's very important because you have two sets of experienced eyes looking at something. So when they're going to pick something up, it's going to tend to be something that makes two sets of eyes concerned, not just one. And I think that is important, that second read feature. Sure, sometimes a computer program can do that as well. The other thing that's really important that sometimes people don't realize is that particularly a screening study is not like a flash picture in one moment in time. The key to a really good imaging result is if you have any previous studies to really do comparison studies. And that often can show, she's had this there for 7 years, so clearly this is not something that we have to act on today. One of the biggest problems and one of the things that patients can do to help themselves is try to be consistent in where they get their screening studies, for example. So if you say, you know what, I heard about this place and I think I'll go there this time, and next year, I think I'll go closer to home, or, that's the kind of thing that can make it very difficult, and that's the kind of thing that makes it difficult for the radiologist to read studies. In general, in our institution, when a biopsy is recommended, the patient is referred to see a surgeon. Now, the surgeon doesn't necessarily do the biopsy, but think of it as another experienced set of eyes who's very familiar with breast disease, looking at that and saying, is biopsy really necessary? Do I agree? Is this something that maybe doesn't need a biopsy, that looks like something that has been there? We have conferences between the surgeon and the radiologist, so that really I think, at least in this system, when a patient gets to the point of biopsy, it really has been thought out by three heads. So the false positive concept is also, it's important that we have to differentiate out what false positive means. To me, a false positive means someone who is told that they have cancer that doesn't have cancer at all. In this day and age, that is pretty darn rare. And again, it's the same idea. All of our pathology is looked at in departmental conference. So no pathology report, particularly on a breast, really ever gets signed out if it's controversial in any way without at least two pathologists looking at it. So the concept of a false positive, meaning that a patient is told that you have cancer but you really don't, in this day and age, it's very, very rare that something like that could happen in a system that has the balances and checks like we do. In addition, if anything is controversial to the two pathologists here, we have a direct line to the Brigham, and we can send it in for yet another set of eyes to look at it, a false positive. Now, you could have a biopsy result that shows that you need to have surgery, and it may not be, what we call a false positive. It may be something that does truly require a surgery. But I wouldn't call that a false positive. The circumstance that leads to that is if a minimally invasive biopsy, such as a stereotactic biopsy or an ultrasound-guided core biopsy, leads to the diagnosis of something called atypia. And so atypia in itself is not a cancer, but when we see atypia on a minimally invasive biopsy, occasionally we recommend that the patient have a little bit more tissue taken out, so a surgical biopsy, to rule out anything more worrisome in that area. The evolution of care in the fact that, so many eyes are looking at a specimen, and then of course, the mundane stuff, which is all the systems that we have in place for patient identification and double checking wristbands, and all of that sounds so like grocery store boring, but it's one of the most important things. These are all safety features that are built into the system.
This is Sue Scheibel, staff reporter for the Patriot Ledger. For more coverage, see today's edition of the Patriot Ledger or go to patriotledger.com.